So it's my great pleasure to introduce Melinda Abrams, who is the Vice President for Delivery System Reform at the Commonwealth Fund and was also a member of the Planning Committee. And then we will hear a voice from above. The click that you heard was Alan Glasseroff, who's the co-director of Stanford Coordinated Care and a clinical professor at Stanford School of Medicine. And they're going to talk to us about an introduction and overview. So now that we've kind of heard Jeremy's story, Melinda and Alan will provide an overview of the issue and kind of begin to frame out the workshop and how we'll move forward. So with that, welcome Melinda.
That way the people in the back can see me. Hi everyone. My name is Melinda. Good morning, and I really want to thank the National Academy of Medicine for this invitation. Foundations are only as strong as the experts and the grantees with whom they partner and with whom they work. So I'd like to acknowledge that I am very much still an eager student in this space, and that I'm indebted to both my colleagues at the fund, my grantees, my intellectual colleagues across the country, and as well as the partners of the Peterson Center on Healthcare, as well as the SCAN Foundation, Hartford Foundation, Blue Shield Foundation. So with that, I'm going to proceed. So here, it's behind me. Okay. So broadly speaking, I hope to cover just a couple of quick issues. One, much of which has already been covered by Peter, Jeremy, and also many of the partners, which is a little bit about kind of the rationale and some of the challenges facing the high-need population, talk about some of the issues in defining this population, talk a little bit also about the Commonwealth Fund's work in this space. So starting a little bit with the fund, Commonwealth Fund's Healthcare Delivery System Reform Program seeks to create a high-performance health system for two populations. High performance is defined by trying to improve outcomes and lower costs, and the two populations are the high-need, high-cost patients, and then vulnerable populations, which we call, which we consider really low-income racial and ethnic minorities, underserved, underinsured. I guess in the spirit of disclosure, because this is somewhat of an academic meeting, I guess I just want to say that the Commonwealth Fund is focused on needs and costs. And so I will you will hear me at some point kind of talk a little bit about the cost side of this, which some others have touched on. So while this is obvious at this point at 9:40 in the morning, and particularly for probably many who already have, who've been here for who were motivated to even come here, but it bears repeating and reviewing the underlying rationale and a little bit of the hypothesis why we are focusing on high-need populations. So high-need patients tend to use more services. The data shows this. There is evidence that the patients are not well served by the medical care system. Jeremy was just one example of ways in which he is well served, but also initially maybe not as well served as could be. And believe that very firmly that there is an opportunity to improve outcomes and reduce costs, that actually we can improve the care of patients, improve the outcomes of patients, and simultaneously reduce the costs and the burden of cost on the system. And there is also emerging evidence that suggests, and some of which we will hear later today, that how this is potentially possible. So jumping ahead really quickly in terms of showing some of the challenges facing high-need patients, here are some results from a Commonwealth Fund International survey. So the sample is patients or people, actually, who are over 65 years of age. High need is defined as 3 or more chronic conditions or people with functional limitation, which Jeremy had talked about IADLs and ADLs, and nobody asked questions about that, but essentially the way we defined it was, limited ability to feed oneself, dress oneself, bathe oneself. And I can get into some of the definitional issues in a minute, but what I really want to show here is that when you look across industrialized countries, you see that patients report that they went to the emergency room for conditions that could have been treated by a regular doctor sometime in the past 2 years. So, and that there are 19% of these high-need Americans and Canadians And it represents significant care fragmentation and unnecessary healthcare spending. For those that are interested in this U.S. sample, more than half of them tend to be women. About half of them are low income, and I can tell you more about them in a minute if you want. Another challenge often facing this population, and again, this is based on a patient survey of people over 65 across all of these industrialized countries. And so we see, as within the previous slide, that the high-need population is especially susceptible to discoordination or a lack of coordination within the healthcare system. What some people may not realize quite as much, but that affordability it continues to be an issue, particularly for this high-need population. So another objective in terms of making care better and the patient experience better and the family and caregiver experience better and more patient-centered is also a goal and an importance of also making it more affordable. So I want to step back for 1 second and talk about this whole concept of need. And one of my punchlines has already been let out of the bag. It's a heterogeneous population. And I'm going to talk more about that. But there is not a consistent definition of need. And that's partially because it is a heterogeneous population and it's really complicated to do. There's been a lot more work looking at cost. But there's been very little written on the characteristics of high-need individuals using empirical data. So a lot of the studies focus on people with special diseases or multiple chronic or disabilities or mental illness. And we should just recognize as we embark on this journey over the next year or so together that this is going to be controversial. At some point, we are going to, and we are currently, and Peterson are currently funding Jose and Ashish and their team at Harvard to kind of identify some of the segments and the subgroups in the Medicare or the duals population. And we're going to need to come up with some of these definitions, and it's going to be controversial, and it's hard to do because there's always this risk of leaving people out. There's always this risk that you're going to cast too wide a net, and then you're actually going to include people that really aren't as high need, and therefore you're also wasting resources. And so that's just part of the challenge and part of the debate. To kind of bring home what many people know, but just a conceptualization of the segments or some of the key subgroups of the high-need population. I refer to this work by Dr. Joanne Lin, who is in the audience. And it's really just, again, to show that it's not a monolithic population. It's rather heterogeneous, and it will affect how the system responds, how the programs are designed, how the payments are structured, how the workforce is trained. And it also, what Joanne and her colleagues did was help to also begin to lay out a little bit of some of the priority issues facing the different subgroups. Another important, for me as a non-clinician, I have always found this helpful as more of a graphic display that shows not just the heterogeneity of the population, but also how different the trajectory of illness is. And you can see that dying with a short period of decline versus those with multiple chronic versus those with a long course of decline, it's just very different trajectory. And therefore, the kinds of programs, the kinds of teams, the kind of intervention that you would put together will be very different. So it's just underscoring with graphically representing and underscoring the heterogeneity of the population. One common approach often used by health systems and others to try to identify the high-need population is to count chronic conditions. And it's understandable, it's a default. And the Commonwealth Fund is fortunate to support Jerry Anderson and his former doctoral student, Eric Roberts, at Johns Hopkins University. Jerry will be here later. Who's done a series of analyses for us to try to help us better understand both the challenges and how to define the high-need population using the MEPS data set. So what you see here is that when you count chronic conditions, it's an incomplete approach because you probably get about 30% of the population if you look at 3 or more people with 3 or more chronic conditions. And there are also many challenges here. Okay, do we count Do we count cancer as a chronic condition? Do we count behavioral health as a chronic condition? Do we weight all chronic conditions the same way? I don't have all the answers to those questions. I can tell you what the Hopkins team and we have puzzled through together, but I think that I'm just here really to raise some of these issues and some of these questions. I think there's some very interesting and compelling work going on at Yale that I heard at the Academy Health meeting. We're really looking at kind of refining some of these multiple chronic condition, these variable in a very thoughtful way that I think could be really useful to this group going forward. So, but the other piece that we have found really comes out clearly in the data, and I think Jeremy's presentation also underscores this, is the role of functional limitations. And that when I have so many more charts, and you'll see unfortunately I should learn more from Diane Rowland and have fewer bars, but this one's not so bad. And essentially, when you look at chronic conditions only, functional limitation only, and then chronic with functional limitation, on almost every dimension, you see that the functional limitation is driving the service use, is driving the cost, and is a lot of ways driving the need. That's not to say that there aren't others in the population that are also incredibly, needy, but I'm just saying that it is a big piece of this. And so when we approached, when the Hopkins team was approaching the MEPS analysis, really thought, okay, if we were going to try to come up with some kind of composite variable to understand some of the challenges facing this population, let's look at chronic condition and functional limitation. So here's the one with way too many bars. So, but I will basically, I'm here to tell you that a substantial proportion, when you're looking at MEPS, a substantial proportion of this high need population, which for the sake of argument, and is more to be illustrative as opposed to comprehensive, three or more chronic with a functional limitation, a substantial proportion are low income, substantial proportion are on Medicare, have a behavioral health problem. When we do look at the under 65 versus the over 65 separately, we do see differences in insurance coverage. The under 65 tend to be more heavily insured by Medicare, more likely to be duals. What I've not shown here is also the differences in some of the utilization patterns, and there are really significant utilization patterns among those with 3 or more chronic and a functional limitation versus just those with 3 or chronic only. And the differences are in everything from prescription fills to hospitalizations to overnight stays to outpatient, and so it's pretty significant. But I would be remiss and kidding ourselves if we didn't actually think that cost was an important part of this discussion. I have very carefully started my presentation with talking about needs, but I do think that this is the slide, and this is the number that Peter mentioned at the beginning about the 5% patients account for 50% of the cost, 10% of the patients account for 65% of the cost. And I do think in many ways this is the chart that is motivating many of the payers and the ACOs and the systems and some of the foundations to really focus on both high cost and high need. But we are very careful and deliberate and planful in saying, it's needs first, that it is about this intersection. And so that the concentration of high cost in the disproportionate few kind of affirms this sense of urgency that we need to address the needs of this population, but also that there is new opportunity, I think, with the Affordable Care Act and with new payment models and new delivery models and population-based care, and a greater interest in the integration that we need to see. I think that this is an important part of the conversation. But the problem is that another default, I talked earlier about how one of the defaults is to just count chronic conditions. Another default is to say, well, let's just focus on the top 1%, the top 5%, or the top 10%. And that would also be a mistake, because what you see in this chart is that 1 year later, only 42% are still high cost in that top 10%. And that a number of the issues resolve. Either they're, an illness that was resolved, or an accident that was resolved, or someone passes away, but there's a variety of reasons. And so if you're going to target or identify high-need patients based exclusively on cost, you're going to miss a lot of people. If you focus them exclusively based on chronic conditions, you might end up with a lot of people who have chronic conditions under control. So I will argue, and this is really the work, again, with Jerry and my colleagues at the Commonwealth Fund, that what we need to go is look somewhere at this intersection between cost and needs. And it's about 37% of the high-cost population are high need, and 36% of the high-need population are high cost. And so it's somewhere at there's this opportunity to improve at somewhere at this in this intersection. But what's missing, and that I don't have data for, but what you will hear hopefully later, which I know you will hear from the programs later, is this whole idea of amenability to change. So when we talk about segmenting the population because it's a heterogeneous group, that's really important. But what we find when we go on the ground and we start talking to programs and start talking to people is that there's another layer of screening that goes on that the care manager or that the program manager does, which is like, which of these patients that fit the criteria, which ones are most likely to succeed? You know, where is there that opportunity? It's this amenability to change. That is really hard to measure, but and I think that maybe we won't have data to actually kind of get us at that, but much more be aware of its value, of its importance, and then turn to the programs and encourage them to do it. The Commonwealth Fund, there are a lot of other presentations today about the models and the programs. We are funding a fair bit of work looking across multiple successful programs for the different subgroups and segments. This is an analysis of analyses done by some researchers at the Commonwealth Fund. I'm not going to read them, but I'm just going to say that there's a lot of promising programs out there. The challenges do, as Peter said earlier, remain around spread and scale. That on some of the features of the program, there is this difference a little bit between kind of content and feature of the program, but also execution and implementation of the program. And then I wanted to also say one of the things when you look at the ground, when you look on the ground and you look at the programs and you talk to the patients, and we're doing video clips and we're trying to kind of understand the needs of the different patients, and we're thinking about pursuing more work on personas of representative patients. So I was really happy to hear Allison and Deborah Ness's question earlier. What you find is what we know, but nonetheless, what you find is the critical importance of linking and integrating both the physical health, the behavioral health, and the social service. This is what a lot of us know, but we don't actually always have the data to support it because there aren't a lot of data sets that actually look across this. I mean, we are working right now actively on trying to develop a few projects that will try to quantify and look at this, and it's very challenging, and I think at the end of the day it will come to looking at a couple of different data sets and juxtaposing a few variables from a couple of different data sets. But what I find really compelling is this conceptual model by David Labby. He's former Chief Medical Officer at Care Oregon. We'll be hearing from Care Oregon later. He's currently Chief Medical Officer at HealthShare, which is the CCO, the Medicaid ACO out in Portland, Oregon. And what David talks about is a biopsychosocial model, and how there are medical determinants, individual behavioral determinants such as risk behaviors, and social environmental determinants such as housing and food and what we call social services or social supports. And what's cool about his illustrative bubbles here, this is more based on his experience than actual quantifiable data, is that given the needs, given what we know about commercially insured populations, the medical bubble is bigger. If you're focusing on a low-income Medicaid population, the social bubble is bigger. And it's just I find it a very useful framework and another overlay. I don't know what this means for the segmentation. I don't know if it's an axis within, if it makes it a three-dimensional model. I'm just, but I can raise it as an issue. Some work that the Commonwealth Fund is planning or is already in the pipeline is further work on understanding the subgroups and the segments of the high-need, high-cost patients, defining and publishing that core group of segments, hopefully in partnership with the National Academy of Medicine. And we are funding a series of work that looking at not just claims, but also survey data, and as I said, considering the development of more qualitative persona-type work. Comprehensive review of promising programs, identifying common strategies that seem to work, a series of case studies on promising programs that will really be targeted health systems and integrated systems and IPAs and ACOs, analysis of Medicare, Medicaid, and a number of other things, and what they mean for high-need, high-cost patients, co-funding a bunch of work with the SCAN Foundation on collaboratives of states in the duals demonstration, as well as also another collaborative with the Center for Healthcare Strategy on health plans serving duals, and how are they going about solving these problems, and what does it look like? But also there's the community level strategies. I was really interested to hear Jeremy talk about that, and to integrate the non-medical services. The work with Betsy Bradley is doing, looking at the community level, work that Ruben Amorasingham is doing, looking at payment models and what could those payment models look like, and how should we be thinking about payment models going forward to encourage that integration of medical and non-medical services. This is just a sampling and a little bit of a flavor of what's going on. But we need to build all of this together. We are only one foundation, and we really look forward to everybody working together. So in summary, in terms of the high-need population is heterogeneous, that was said at the outset, but tried to kind of just show it graphically, that we do believe that the best opportunity to improve care for high-need patients lies at the intersection of need, spending, and amenability to change. There are many choices and many questions around definitions, and I would encourage us to consider them, debate them, but not belabor them. We need to just make some decisions and move on so that we can create a more actionable agenda for health systems and for Medicare, Medicaid, and private payers. That the social support and the behavioral health needs of this population and its multiple subgroups are critical. And that while there are many programs that exist, there are substantial challenges to the spread and scale that range from workforce training to payment models and a number of other, and infrastructure needed for the integration. So with that, I will close, and thank you all very much. And I just wanted to thank my colleagues.